Welcome to the Queen of Hearts podcast. And here's the queen herself, registered dietitian Heather Klug.
Hello, everyone, and welcome to the Queen of Hearts podcast. Today with me is Bethany DeBrew-Adams, my co-host. So welcome,
Hello.
Bethany.
Thank you, Heather. Thanks for having me on.
Yes, so happy World Menopause Month, ladies.
But you didn't even know that was a thing.
Yeah. Menopause is one of the biggest life and health changes that women undergo, and today we want to shine some light on what it is and how going through it impacts the heart. This is also a very interesting topic for both Bethany and I, since we are heading closer to that lovely phase in our life. So we both always like having more information about things, so we're not surprised. And we will also be talking with Advocate Aurora cardiologist, Dr. Patrycja Galazka, about perimenopause, menopause, and the changes both phases bring. We have a lot to cover, so let's get started. So, Bethany, how about we first talk about what menopause actually is?
Yeah. And okay, so this is the best thing right here. This is the easy part. Menopause itself is a very easy thing to denote. Strictly speaking, it's the time that marks the end of your menstrual cycles. So it's diagnosed after you've gone 12 months without having a menstrual period. And that, ladies, is the end of the easy part of menopause, right?
Right?
So,
That is true.
yeah. So let's get into kind of the nuts and bolts here about what causes menopause. I think we all kind of know the basics, but did you know that there's more than one way that menopause is caused?
Yeah, there's actually 4 different things we're going to go through, right? So the first one is the natural decline of reproductive hormones. So I think most people know hormone levels go down. And as you approach your late 30s, your ovaries start making less estrogen and progesterone. And those are the 2 main hormones that regulate menstruation. And your fertility also declines during this time. And then in your 40s, your menstrual periods may become longer or shorter, heavier or lighter, more or less frequent, until eventually your ovaries stop producing eggs and you have no more periods. Basically, your periods change. Your periods change during that time, right?
If they're different than they were before, I should just say that.
Yeah.
So the second thing that can cause menopause is a hysterectomy. And there's 2 types of hysterectomies. So the first is the type that removes your uterus, but not your ovaries. And that actually doesn't cause usually immediate menopause. So although you no longer have periods because your uterus is gone, your ovaries are still releasing eggs and still producing estrogen and progesterone. But if you have a hysterectomy that removes both your uterus and your ovaries, that does cause immediate menopause, which sounds to me like it would just be the most unpleasant thing that you'd have to go through, because your periods stop immediately and you're likely to have hot flashes and other menopausal signs and symptoms, which can be severe in this case because your hormonal changes are happening abruptly rather than, for a natural menopausal period that would take several years. So it just, that doesn't sound like fun.
No, I've talked to quite a few women when they come in for resting metabolic rate measurements who, did have surgical menopause, and it did not sound like fun at all because it was exactly how you described. It was very abrupt and everything was happening in a short amount of time. All right. So the third way a woman can go through menopause is because of chemotherapy and radiation therapy. And we talked about this a little bit in the breast cancer and your heart podcast too. So if you didn't hear those yet, please go and listen to those. But these cancer therapies can induce menopause, causing symptoms such as hot flashes during or shortly after the course of treatment. And just so women know too, the halt to menstruation and fertility is not always permanent following chemo.
That's good.
So it can happen, but not always.
Yeah. And the final way that women can end up going through menopause is something called primary ovarian insufficiency. So about 1% of women experience menopause before the age of 40, which is very early. And menopause may result when your ovaries fail to produce normal levels of reproductive hormones stemming from genetic factors or autoimmune disease. But oftentimes, no cause can be found. It just starts happening. And for those women, hormone therapy is typically recommended at least until the natural age of menopause to kind of protect them from going through these changes far too early.
All right, next we'll talk about some symptoms that you may experience during perimenopause and menopause.
Hold on
And
to your hats, everybody.
and Dr. Galazka is going to go through some of these too in our interview with her. And just so everyone's aware too, that these symptoms you experience can be anywhere from like 2 to 10 years is what I've read before you actually go through menopause. The average is about 4 years for most women. And we don't fully know all the things that go into, okay, why do some women seem to go through it faster or have a shorter perimenopausal window compared to other women? Dr. Galazka will get into some of that as well. But basically, a lot of these symptoms can affect multiple parts of your body. I think the ones most women know about, certainly hot flashes is usually the biggest one. And then along with that, a lot of women get night sweats, which can also lead to trouble sleeping, right?
Yeah.
The other big ones I hear about too are like mood changes.
Yes.
Where the mood changes. It's like you could either be like really kind of sad or angry, or
Yep.
you may vacillate between the two with very little notice.
Shifting without a clutch is what I've heard that being called. Yeah.
Ooh, okay. And then there's a few other things too, like the urge to urinate more frequently. There's things that can affect your skin. So your skin may become more dry, or you may have really itchy skin. You may also have, more fatigue. There may be some dizziness, some digestive issues. Hair loss is another big one that tends to occur. You can have breast pain, joint pain. What am I forgetting in here? Oh, you have memory lapses. I didn't plan that. Yeah. See, I may be in perimenopause already. I had just had a memory lapse. And then the other big one is usually weight gain. And we're going to get into that in a little bit.
Okay. I think it's also important to point out not everybody's going to have every symptom.
Yeah.
Things are
So
different.
don't be scared.
Don't be scared. We say these things because, like Heather said, we like the most information. In cases like this, we don't want to be surprised. So menopause causes several things, obviously, like Heather mentioned, to change in a woman's physiology, but also it raises the risk for certain conditions and certain diseases that might come about. And the first one is osteoporosis. And I think most people have heard about this. It causes your bones to become brittle and weak, which leads to an increase of fractures. During the first few years after menopause, you may lose bone density at a rapid rate, which increases your risk of osteoporosis. And postmenopausal women who have osteoporosis are especially susceptible to fractures of their spine, their hips, and their wrists.
Yes. So right around, I would say in perimenopause and, menopause and the few years after that is a super crucial time for bone health. So making sure you take care of yourself, eating a wide variety of foods to get the nutrients you need and getting in the exercise to keep that bone density as strong as possible, because it does continue to decrease over time.
Yeah. So primarily, like you're saying, about your 40s to like your mid 50s is the most critical.
Yes. So the next condition to talk about is urinary incontinence. As the tissues of your vagina and urethra lose elasticity, you may experience frequent, sudden, and strong urges to urinate, followed by an involuntary loss of urine, or the loss of urine with coughing, laughing, or lifting, which they call stress incontinence.
Yeah.
You may also have more frequent UTIs as well. So I think the big thing here is do your Kegels, keep those muscles nice and strong down there.
Definitely. That will also help in this next area, which is sexual function. So vaginal dryness from decreased moisture production and loss of elasticity can cause discomfort. And even for some ladies, it can also cause some slight bleeding during sexual intercourse. And there's also possibly a a decreased sensation. And all of these things combined, including, the drop of estrogen that you're also experiencing and the mood stuff, you might lose your desire for sexual activity. Definitely sounds like you wouldn't be much in the mood at that point.
Oh, okay. All right. The next thing to talk about is weight gain. And many women gain weight during the menopausal transition and after menopause because metabolism slows. And according to the Healthy Women study, the average weight gain is actually only 5 pounds. I was
Wow.
really surprised by that. I thought it was going to be a lot more.
Yeah.
However, 20% of women in that study gained 10 pounds or more. Now, a lot of this they think has to do with estrogen levels going down. And when estrogen goes down, that may lower your resting metabolic rate, believe it or not. I mean, your resting metabolic rate goes down. I mean, every decade it goes down a little bit because
Right.
there's this natural loss of lean muscle. But in animal studies, estrogen appears to help regulate body weight. And with lower estrogen levels, lab animals actually also tended to eat more and be less physically active. So, not a great combination. So,
No.
estrogen goes down, it makes us want to eat, and it makes us not want to exercise. So, I think that's a good thing to be aware of
Yeah.
so that those are things we can really focus on. You may not have that desire to want to go move your body and exercise. You may have to talk yourself into it, and you might have to talk yourself out of, snacks or,
Right.
eating that second helping or more of something. So those are just things I think we have to be just a little more careful of. And on average, women really need about 200 calories less in their 50s than in their 30s and 40s. So just something to kind of take into consideration too.
Yeah.
And then the last thing I'll just say about the weight gain is that unfortunately the weight we gain tends to shift and it moves to the midsection, which is increasing what's called our visceral fat, which most of us know is not the healthy kind of fat. And Dr.
Mhm.
Galazka is going to talk about that a little bit more because that does increase our risk for heart disease, high blood pressure, and type 2 diabetes as well.
Right. And you actually just said what I was going to say.
I'm sorry.
When our estrogen levels decline, the risk of cardiovascular disease and heart disease in particular increases. And to talk more about these issues is our special guest.
Joining us today is Dr. Patrycja Galazka. She's a cardiologist with Advocate Aurora Health and Aurora St. Luke's Medical Center. Her specialty is in non-invasive imaging, and her passion is in women's cardiovascular health. So welcome, Dr. Galazka, and thank you for joining us today on the podcast.
Oh, thank you so much, Heather and Bethany, for having me today. It's a pleasure being here and speaking about a topic which is very dear and near to my heart, and that is women's cardiovascular health.
We're so happy again that you're with us today. Now, first things first, can you explain the difference between perimenopause and menopause and how a woman can tell which phase she's in?
It's a fantastic question, Heather. I think menopause is an important topic that we should be discussing because each one of us will either go through it in the future or has gone through it and will experience certain symptoms which we'll need to be aware of. And menopause essentially hallmarks of reproductive time in women's life and is diagnosed clinically by cessation of menses for 12 months. So that is sort of the definition. I wanted to give you some statistics in the USA that we have here. And most women who undergo menopause are usually between age of 40 to 55 years old. An average age of menopause is roughly 51 years of age. And there's very few women who unfortunately will experience early menopause. So that is before the age of 40 years old. And that's less than 1% of women, whether it's because of natural causes or surgical causes. Now, menopause, again, is defined by cessation of menses for about 12 months, but before we enter that menopause or before we have our last period, we go through perimenopause, and that is sort of the transition before the menopause. And that's when the menstrual irregularities begin and periods start to change. And at the same time, there's physiological and hormonal changes which occur in women's body. And perimenopause can last for a variable amount of time, the median of which is about 4 years. years. And traditionally, perimenopause has an early and a late stage. And the early stage is defined just by occasional skipped cycles, versus the late stage is characterized by greater menstrual irregularities, which can last for without basically a period of about over 60 days and up to 12 months. And during those times, there's physiological changes and hormonal changes that essentially result in ovarian decline in function. And during that late stage of perimenopause, what happens is women start experiencing vasomotor symptoms, such as hot flashes, vaginal and sexual changes, altered mood and sleep disturbances, which can be truly life-impairing and can have an effect on us as well as people who are around us. And some women would spend more time in this early perimenopause. Some women would spend more time in late perimenopause stage where you start having those symptoms, and those symptoms can go on even after menopause. There's factors which impact the timing of the menopause and how much time we spend in it. And one of them is a maternal age. So when your mom had her menopause, you're more likely to have it around similar time. Also, smoking and alcohol use can influence those phases, your body mass index, and also socioeconomic status, which actually has been shown in one of the bigger studies, which was done, the SWAN study, which is the study of women's health across the nation. What they've shown that there's racial and socioeconomic disparities, which influence the timing of menopause, as well as how much time we spend in perimenopause and menopause. For example, in that study, they've shown that African American women had longer duration of going through the transitional period of perimenopause than white women, and greater body mass index was associated with a later onset of menopausal transition. So these are some of the very important things which we should be aware of, and that's where healthy lifestyle comes into, which we'll talk about in very few minutes. But there's few laboratory tests which we can do to sort of know if we're going through that period, once we start having symptoms of even before that. And we can check FSH or estradiol levels, and these can be highly variable in women's bodies. So I would highly advise everyone to speak to their OB-GYN specialist to sort of see what is normal for you and if we can tell whether we're going through it.
Okay, that's very interesting because you said a lot of stuff that I didn't know right there, especially the socioeconomic impacts on perimenopause. That's fascinating to me.
Yeah, that's new to me too, Bethany.
Yeah, very surprising. I mean, it's surprising, but it's not surprising because we're finding out that those kind of factors impact a lot of different aspects of health. So what are the specific impacts to heart health that we see in perimenopause and then once the menopause transition takes place?
Very, very important question to ask for each woman. Thank you for this question, Bethany. As we know, cardiovascular disease is the leading cause of death among women in the United States. So that's a very important statement that we need to be aware of and share amongst each other, because we have to take a better care of ourselves and especially of our heart. And beyond the traditional cardiovascular risk factors such as smoking, greater age, diabetes, hypertension, hyperlipidemia, women also have very unique risk factors, and such as early menopause or preeclampsia, so hypertension or high blood pressure during pregnancy. And these risk factors actually have been acknowledged recently by American College of Cardiology in 2019 primary prevention guidelines, where they were essentially said to be risk enhancers. So early menopause or menopause before age 40 or preeclampsia are considered to be these early risk enhancers to sort of tell us whether a woman is at an increased risk of cardiovascular disease. There's other factors also in women which are very specific for women. And then there's adverse pregnancy outcomes such as gestational hypertension, again, gestational diabetes, preterm delivery, and delivery of small gestational age infants are all unique cardiovascular risk factors to women. So we all should be aware of them because they all have impact on our cardiovascular health. And as we know, during menopause, women go through abrupt change in hormones. Specifically, there's a decline in estrogen levels. And that is in comparison to men, where men's testosterone declines over a decade in a slow manner. Women sort of go through this abrupt change. And during this abrupt change, we specifically go through metabolic changes as well. And one of them is increase in adipose or visceral fat deposition in abdomen and abdominal cavity. Our cholesterol becomes sort of wacky or changes. We have increase in LDL, which is the low density lipoprotein, which is the bad cholesterol. Our triglycerides starts going up, which we know are one of the factors at increased risk of cardiovascular disease. And also there's a decrease in high density lipoprotein, which is the good cholesterol. So there's not so good changes going on with our cholesterol. There's also insulin dysregulation, which occurs during menopause, which leads to increase in insulin resistance and decrease in insulin secretion, which may eventually lead to diabetes. On top of it, there's endothelial dysfunction. So because of that, we may not have as good of vasodilatation because of certain hormonal changes. Our blood pressure may go up and our sympathetic tone goes up. So altogether, all of these can lead to accelerated cardiovascular risk. So it's very important that we're aware of these metabolic changes that occur during menopause, because eventually we want to battle that sort of number one killer of women in the United States, which is cardiovascular disease.
Dr. Galazka, are there any drawbacks to heart health from treatments for menopausal symptoms?
Thank you for asking this question, Heather. So as we know, during perimenopause and during menopause, we experience a decline in our ovarian function or estrogen decline. And because we do not have enough estrogen or other hormones, we start experiencing these vasomotor symptoms. For that reason, for many years and for many decades in the past, people believed, based on observational studies and epidemiological studies, that a hormonal replacement therapy could be something that could be potentially beneficial to women's health, that it could potentially improve insulin resistance, improve vasodilatation, increase nitric oxide production, decreasing inflammation, as well as regulating the cholesterol, so making the good cholesterol go up and the bad cholesterol, LDL, go down. So these are sort of the thoughts that were believed in the past, but as we have learned to know based on randomized controlled trials more recently, these thoughts have changed. And we know now that based, for example, on one of the studies that was done, the HER study, which is the heart estrogen/progesterone study, based on over 2,800 women, which studied women who were in menopause and who had cardiovascular disease. This study showed that there was absolutely no benefit for taking hormonal replacement therapy in regards to cardiovascular disease prevention. But there was actually some of the warning signs that came up with it. And these women, essentially, it signaled that these women might have had increased cardiovascular disease events during that study. There was another study, which was a pivotal trial, a women's health initiative, which was published back in 2002, which again looked at women who were postmenopausal and who did not have cardiovascular disease, and showed that hormone therapy does not decrease risk of cardiovascular disease in women, but also raised concerns that there may be trend towards harm. So these are the important things which we should know and we should discuss with our providers or our doctors. Overall, during that study, there was no increase in mortality with hormone therapy, but further data showed that women who received hormone therapy had twofold greater risk of thromboembolism. There was probably increased risk of stroke in older women and possible increase in cardiac risk in older women as well. So yes, there are potential drawbacks, especially when it comes to cardiovascular health, which we should be essentially aware of. And we should know that estrogen therapy or hormone replacement therapy is not recommended at this time to be prescribed for cardiovascular disease prevention due to some of the unfavorable effects. Now, currently, FDA approves hormonal therapy for treatment of vasomotor symptoms in certain women, for prevention of osteoporosis, treatment of the genitourinary symptoms, and to replace premature loss of estrogen associated with surgical menopause or premature ovarian insufficiency, so premature ovarian failure. And when we essentially see patients and we talk about hormonal replacement therapy, I think there's few factors which should be taken into consideration. There's the age of initiation. So for example, younger women may have less sort of harmful effects effects, the time of menopause. So, for example, women who are 10 years out of menopause should not be taking hormonal replacement therapy. Women who are over 65 years of age should not be taking hormonal replacement therapy. And then we have to also consider the duration therapy and the type of hormonal replacement therapy, for example, dose and route. So when we see patients again, I think it's the first thing that we normally do is we will sort of assess a woman's cardiovascular risk. So we want to know whether she falls into a low risk category, whether she falls into the middle risk category or the high risk category. And if she falls into a low risk category based on the ASCVD equation or calculator that takes into account cholesterol, age, as well as other factors, and she doesn't have any other history of, for example, stroke, cardiovascular disease, or peripheral arterial disease, or history of thromboembolic events, then we may, and this woman is younger, we may consider hormonal therapy. So there's a lot of factors that go into it, but I think we should be aware of potential harmful or potential sort of adverse effects, which have been shown in some of the trials from the past.
So given that, like you said, sometimes hormone replacement therapy does more harm than good, or it doesn't really apply for women, what are steps that women can take themselves before and during perimenopause, and then kind of, through the whole process to keep their hearts as healthy as they possibly can keep them moving into the future when now you've gone through the change of life and you're through menopause and moving forward?
I think the number one thing that we should do are the lifestyle changes. So essentially following healthy diet, full of vegetables and fruits, exercise regularly, making sure that if required, we lose weight and we keep it within normal levels. We know that there's yoga, stress reduction therapies, which can be helpful, and especially avoidance of tobacco and alcohol, avoidance of spicy foods. Hot beverages can actually be helpful with the vasomotor symptoms. And what I want to point out that when we talk about hormonal therapy has changed over time. When these studies were conducted, which showed harmful effects, these women were taking oral estrogen with progesterone replacement therapy. For now, we have a lot of other options. So for example, we don't necessarily have to take oral estrogens. There are transdermal patches, which we can have if needed, if the symptoms are severe enough. There are also gels and other topicals for genitourinary symptoms. So these are some of the important factors to discuss with your either OB-GYN or your primary care physician, because the dose and the route is very important. So obviously less is better, and sort of the less oral route is better as well. There's other sort of non-hormonal treatments which can be considered if the symptoms are severe enough. And these are the selective serotonin reuptake inhibitors, so such as paroxetine. A low dose of it is actually approved for these vasomotor symptoms in women where they are life impairing. And we also know that there's non-hormonal sort of treatments such as black cohosh, red clover, flaxseed, but these have not been found to be more effective as compared to the placebo. So I think number one is lifestyle changes. I think if the symptoms persist, we should talk to our doctors and we should sort of discuss other alternatives, whether it's in the transdermal patch or topical agent, a lotion, or even potentially SSRIs or other medications which can be helpful. It is important that our symptoms are well controlled. And as I mentioned before, some women will experience more symptoms, some women will experience less symptoms. But number one is to know your risk factors, essentially your ABCs of prevention. You want to know your numbers for blood pressure, whether it's normal. You want to know what is your cholesterol, whether it falls within normal limits. You want to know whether you're a diabetic or pre-diabetic, what is your glucose level. E is for exercise, so you want to make sure that you exercise regularly and get at least 150 minutes of exercise, of moderate intensity exercise per week. So these are very important things. So number one thing is knowing, taking charge of your health, and sort of following through with this very healthy lifestyle.
All right, Dr. Galazka. So if there was one key message you wanted to get across to all of our listeners, what would that be?
Heather, I would like to say that knowing, again, your numbers and your individual risk is one of the most important things, but also having an honest conversation with your doctor, with your physician. A shared decision making between you and the physician is extremely important in regards to hormonal therapy and sort of taking on the lifestyle changes and going towards betterment of cardiovascular health.
Well, thank you again, Dr. Galazka, for being with us on this episode today and for sharing your knowledge with us on perimenopause and menopause, because perimenopause and menopause can be a crazy time for women, but it's important to remember that they are both natural phases in a woman's life. And like everything else, there are things we can do to prepare ourselves for what's coming. I'm going to keep this info in mind because I'm getting close to this time in life. So I love.
Aren't we both?
Yes.
Aren't we both?
Well, I love these tips that you shared today. So by talking to your healthcare provider early, you can learn how to manage your symptoms and get on top of any physical issues, including cardiovascular issues that may be developing. This is a great time of your life to take control. Thanks for listening, everyone. And as we always say, be the ruler of your own heart. Goodbye.
Bye-bye.
Thank you for joining us on the Queen of Hearts podcast. Our podcast is recorded here at the Karen Yance Women's Cardiac Awareness Center inside Aurora St. Luke's Medical Center in Milwaukee, Wisconsin. For more heart-healthy tips, info, recipes, and more, visit our website at www.karenyancecenter.org. Like us on Facebook at Karen Yance Center and follow us on Pinterest. If you like what you hear, subscribe to our show and be sure to tell your friends. Until next time, ladies, be ruler of your own heart.